Okay, so let's go ahead and pick up where we left off. Still working on respiratory system. And so when you take a look at the respiratory system, we're going to be kind of left off talking a little bit about the gas exchange piece. We kind of looked at the whole system where you're looking at gas exchange in the lungs versus gas exchange in the tissues. And so when you're taking a look at gas exchange, the important thing to remember is gases will exert pressure. And so the pressure itself is basically what causes the flow of the gases. And so gas is technically a fluid. It's got all the dynamics of fluid in terms of its flow. And so as a result, when you're taking a look at the movement of gases, they're generally flowing according to their what's called their partial pressures. And when you take a look at their partial pressures, this is another gas law. It's actually like in anatomy and physiology, we go a little bit more in depth with more gas laws than we have here. But this is one of those gas laws called Dalton's gas law. So what Dalton's law essentially is, for just kind of like the brief definition of it, is when you have a mixed gas, right? So like our atmosphere, which is composed of multiple gases, right? Oxygen is one of them. CO2 is one of them. Nitrogen is the biggest component, but you have multiple gases in this overall mixed gas. And of course, the atmospheric pressure of all these gases is like 760 torr, millimeters of mercury, or 1 atmosphere, depending on which unit you want to use. Now, the idea of the pressure of the total gas, like 760 millimeters of mercury, is defined by Dalton's law as being the sum of all the individual gases that are in the mixture. So for instance, oxygen will have its own particular pressure that it adds to the total of that 760. CO2 will have its own particular pressure that it will add to the total of that 760. And that individual pressure is what's called the partial pressure. So what this does then is, when we were talking about oxygen going down its pressure gradient from high to low, it's not just atmospheric pressure. That does govern how the air goes into and out of your lungs. We talked a little bit about that earlier, right? But when you're talking about actual oxygen going from your blood into your lungs, as opposed to from in your lungs into your blood, right, depending on the direction, it's not following necessarily the atmospheric pressure, it's following its partial pressure. And so it's responding specifically. And what this does is, this is what allows us to be able to get that two-way flow of the gases. It's what allows us to be able to get oxygen in, while at the same time simultaneously getting CO2 out, right? Because if it were just air pressure, then everything would be going in one direction, and that wouldn't be helpful for us. And so having this partial pressure be the driver of gas exchange is important. It allows us to be able to cherry pick and choose which gases we want to keep and which gases we want to get rid of. And so all of them, however, will still diffuse from high to low. And so it's going to be obeying and looking at its own partial pressure. Now, with external respiration, basically, this is where we have gas exchange going on between the alveoli and the lungs and those capillaries that we saw earlier in the chapter, that were basically wrapped around each of these little alveolar pockets or alveolar sacs. Now, generally speaking, inside your lungs, excuse me, not the lungs, but the lung capillaries, the blood, your PCO2, your partial pressure of CO2 is going to be really high. Why? Because ultimately it's the waste product that you've been generating from cell respiration. And so it's been building up inside your body. And so since it's high on the inside and not so much on the outside, then it's going to diffuse from high to low. It's going to be leaving the blood and going into the lungs, because the partial pressure of CO2 inside of us is much higher than what's in the atmosphere. Okay. The converse is also true, right? So you have to have the same kind of an idea for the intake of oxygen. And so it's going the opposite direction. So ultimately, when you take a look at the red blood cells, the partial pressure of oxygen is very low in the red blood cells, and in the pulmonary capillaries, excuse me, opposite direction, is very high in the okay, opposite direction again. Sorry. I'm like thinking in one direction and the slides are in the other direction. Okay, so you're oxygen depleted in your red blood cells, right? Because you basically used up all of your oxygen to do cell respiration. And then in the lungs themselves, it's going to be very high because it's atmospheric, right? And so that basically sets up your gradient, your high and your low. And so from here, then you're going to be flowing from high to low. That means from the alveoli into the red blood cells that are in your pulmonary capillaries. Okay. But you basically have two things happening at the same time. So for instance, when your CO2 is coming into the lungs, into the blood, it's going to be much higher in partial pressure. A lot of that CO2 is broken up and carried in the blood in multiple different ways. One major way that you carry CO2 in your body is with your bicarbonate or your carbonate buffer system, right? So for instance, if you take a look at your CO2, add it to some water, then that's going to turn it into carbonic anhydrase, which then dissociates into bicarbion and hydrogen. This is basically the backbone of your physiological pH. However, when you come to your lungs, what happens is you can back this up and you can move this reaction in this direction so that it causes the CO2 to fall out, if you will, for lack of a better term, out of the water, and then you can breathe this out. And that can go into the lungs itself. It's think of it sort of like analogous. It's not completely perfectly like this, but think of it as sort of similar to the way that you get CO2 out of a 2-liter Coke, right? So when you take a look at a 2-liter Coke, you don't see any bubbles inside of it initially, right? That's because it's dissolved in the fluid itself. But when you change the pressure, then all those bubbles come out. That's the gas coming out of solution, and then that gas is able to dissipate out into the atmosphere. And so you can kind of do the similar sort of a thing. When you think of the carbon dioxide as being part of this carbonate buffer system, it's kind of like the gas of CO2 in a soft drink being dissolved in a liquid. And then you can back it up and you can liberate that CO2. It'll come out as a gas, and then that will basically move into your lungs so that you can breathe it out. Sort of the same way that the gas comes out of solution when you pop the top on a 2-liter bottle. So carbonic anhydrase is the one that is responsible for this breakdown. So essentially, it is going to facilitate the incorporation of CO2 into water in the form of carbonic acid. And then that's going to be in the red blood cells. Now, when you take a look at perturbations of the system, of this carbonate buffer system, then you have a couple of major carbonates, how should we say, they're not necessarily pathologies because they're not necessarily disease state, but different ranges of maybe your homeostatic cycles, right? So what is hyperventilation? So you can affect your CO2 concentrations by either hyperventilation. So basically you're breathing at a really, really high rate. So what this basically means is you're pushing the reaction to the right. So in this direction here. And so a lot of your CO2 is being liberated and it's being breathed out. And so as a result, since you're breathing it all out, that means your pH levels are going to start to, this concentration is going to start to crater, right? You're going to lose your hydrogen ion because you're breathing it all out in the form of carbon dioxide. What that means is there's not going to be enough hydrogen ion around to make your blood buffer acidic. And as a result, it's going to get more and more alkaline in nature because the molecule that creates acidity is disappearing because you're breathing it out. And so in this case, it'll result in what's called alkalosis, or the increase in your blood pH. Now, hypoventilation is the opposite, right? So this is basically when you're not breathing enough, so you have a low rate of breathing. This is going to be hyperventilation. And then hypoventilation, where you're not breathing enough, is going to push it to the opposite direction. So because you're not breathing enough, most of your CO2, which is still around, is going to basically get converted into the carbonic acid form. And then it's going to fall apart and it's going to create excess amounts of hydrogen ion, which is going to create the opposite effect. In this case, it's going to acidify your blood buffer and it's going to create a lower blood pH. Now, the good thing is, it's very easy to adjust this because all you have to do is just kind of get back to your normal rate of breathing, right? So it's very simple. And that's one of the reasons why, like if you're hyperventilating or hypoventilating, the first thing to do is to reestablish that normal tidal oscillation that you have at rest, because that basically is what will allow you to avoid sort of the acidifying of your blood or the alkalinization of your blood by either loss or gain of CO2. So then when you take a look at the oxygen levels, so that's the CO2 story on external respiration. Let's take a look at the oxygen situation. Generally speaking, you have a much higher partial pressure of oxygen in the atmosphere that you just breathed in than in your tissues. And so as a result, it's going to be moving from high to low, means it's going into your red blood cells that are wrapped around your lungs. And then once it's in your red blood cells, it'll be bound by hemoglobin and it'll become oxyhemoglobin. So for instance, here's an example. In your red blood cells, you have a molecule of hemoglobin, which is a tetramer. And then each of these individual units has a heme group. And then when you breathe in your oxygen, each of these hemes will bind to an oxygen and it'll give you oxyhemoglobin, right? So basically hemoglobin is designed to bind to the oxygen very specifically. A little bit different than the way that you carry CO2, right? It's a little more purposeful. It's a little more targeted, okay? So then when you have your oxyhemoglobin, this is basically what's leaving the lungs. And it heads toward the systemic side of the heart. And then once it gets pumped out to the rest of the body by the left ventricle, now you have oxygenated hemoglobin, oxyhemoglobin going out to the tissues. So it's going to be going through those capillary beds in the tissues themselves. And at this particular point, the partial pressures flip. So now instead of the high partial pressures of oxygen being outside of the red blood cells, it's now inside the red blood cells, right? Because remember, the tissues have been busy using oxygen, doing cell respiration, and then generating lots and lots of CO2 as a byproduct. So as a result, they tend to be somewhat oxygen deficient. And so in the tissues, you have a low partial pressure of oxygen and a high partial pressure of CO2, right? Because you're consuming oxygen, you're generating CO2. And in the blood capillaries, it's just the opposite. You have a high partial pressure of oxygen and a low partial pressure of CO2. And so now basically you just follow your diffusional pathways. So oxygen is going to be moving down its pressure gradient. And so it'll basically give up the oxygen and it'll move into the tissues. So it's going to go from high to low, going from the blood into the tissues. The CO2, on the other hand, is going to be doing the opposite, right? So since it's high in the tissues, because it's your waste product, you've been building up a lot of trash, then it's going to be going into the blood because the blood looks lower, relatively speaking. Okay. So you can see you have this two-part system associated with respiration. So when the oxygen diffuses out of the blood into the tissues, this is basically following its partial pressure gradient. And the carbon dioxide will follow the opposite, also following its partial pressure gradient. And then ultimately that'll be loading CO2 into the bloodstream for elimination and delivery to the lungs. And then oxygen will have been delivered to the tissues, where the tissues are needing the oxygen to continue to do their cell respiration, right? So you have two different types of respiration: external respiration, where you have the exchange of oxygen and CO2, and then the internal respiration, where you have also the exchange of oxygen and CO2, only it's the opposite direction. So it's the delivery of oxygen and the pickup of CO2, as opposed to the delivery of CO2 and the pickup of oxygen. Okay. Let's take a look at some disorders of the respiratory system. First of all, you have infections. That's a common one. So you can get these from, usually they're virally spread. So it's usually viral in nature. Sometimes it can be bacterial. Most of the time they're viral. But this can be transmitted either through the nose, the nasal cavities, the pharynx, pretty much any of your head openings is where it is actually transmitted to. And so it spreads throughout your respiratory cavity. So basically this is kind of like head cold. Oftentimes we refer to this as a head cold colloquially, right? Or head congestion, things of that nature. So these basically stay in the upper regions, and they don't oftentimes make themselves any further down. However, you can obviously get them down into the lower respiratory system. And so you've probably had those, right, where you've basically either had some sort of a viral infection that's largely just been in your head, and it's giving you a lot of congestion, a lot of misery, right? But then it kind of clears out, and then everything's okay. And then you probably had some where it kind of seems like it starts in your head, and then once it clears out of your head, you kind of feel like it starts to shift down into your lungs, right? So that's kind of also a pattern that you see. So of the viral infections that you see, oftentimes colds, this is adenovirus. Those are the sorts of things. That's probably the most common upper respiratory infection that we run into. So you got the whole sneezy, runny nose, mild fever kind of a thing. And so you can have irritation of your sinuses. So sinusitis is basically an irritation of the sinuses. Usually a blockage because you get a lot of buildup in the sinuses, and then they get blocked, and it creates a lot of pressure. You get that sinus headache thing going on. And a lot of times this can be bacterial in nature. So they'll oftentimes you go to the doctor for sinusitis, they'll give you an antibiotic for that, to kind of clear out that bacterial instigator, if you will, that's creating a lot of that buildup and discharge. Because remember, your body's not just building up discharge, mucus, and all that sort of stuff just for kicks and grins, right? It's not just doing that just because it wants to. It's typically responding to something. So the reason why you get all mucusy and runny in the nose is because there's some sort of a virus that your body is responding to, or some sort of a bacterial infection that your body is responding to. Okay, so you don't just get runny noses for no reason. Okay, and so that's an important thing to remember. Of course, tonsillitis is inflammation of the tonsils, and if this becomes bad, then you have to have a tonsillectomy, which is basically surgical remover. But this has to be bad, right? This has to be chronic and typically bad. You don't just, it's not like the 50s, right? Like in the 50s, it was just like, it was kind of fashionable, if you will, to go get your tonsils out. It was just like, oh, hey, you got tonsils in there. Okay, let's take them out. Why? They're doing their job, right? I mean, you don't just take them out because they're there. That's kind of what they did in the 50s. They did all sorts of dumb stuff in the 50s by taking out your appendix. Oh, let's take out your appendix. It doesn't do anything useful. Really? Actually, it does. Because the appendix is, as we learned, is actually part of the lymphoid system, right? So it actually does have a job. So do the tonsils. You don't just take them out just for kicks and grins. There's no such thing as discretionary surgery in your body. There's nothing useless in your body that needs to just be taken out. We can miss and not care about, right? So everybody has a job to do. Just because we don't know what the job is doesn't mean that it's expendable, right? And so the only reason why you take out your tonsils is because when you get sick, chronically so, the tonsils swell up so much that they threaten to block your airway. That's the reason why you take them out, not because you've got them, right? So, or because you can see them. Of course you can see them, right? I mean, they're there. You're supposed to see them. It's whether or not they're actually creating a chronic blockage of your airways. So tonsillectomies are a little bit more reasonably done these days. Of course, laryngitis is basically an infection of your voice box. This is basically when you start to lose your voice, or you start to, and you can kind of feel it, right? A lot of times when it starts to get to lower respiratory, you can kind of feel your voice change. You go from maybe a soprano to a contralto, or if you're a male, you go from like a tenor to a bass, right? And you kind of start to get that that voicey sound, and everybody, as soon as you open your mouth, kind of shuns you because they realize you shouldn't be sounding like Barry White. That's for all you Barry White fans. It's classic 70s. Go listen to them. But then the lower respiratory, these guys are a little bit more dangerous, right? Now, the upper stuff, that's fine, right? Because that's a good chunk of what we deal with throughout the year. I mean, it's annoying. That's true. It gets us stuffy in the head. But for the most part, it's livable, right? I mean, nobody's going to fall apart because you got a little bit of an upper respiratory thing going on. However, lower respiratory is a little bit different, right? So here, you can certainly obviously get infections of the lower respiratory system, just like you can of the upper respiratory system. You can restrict the pulmonary pathway, or you can obstruct it, right? And lung cancer. So these are some of the big ones that will basically create infections. These are all pretty serious stuff, right? So you don't typically want to mess with your lower respiratory, because at that particular point, what you're talking about is the fundamental functionality of your lungs themselves. Okay, and that's kind of a bad situation. So what are some of the infections? Well, we got bronchitis, which is inflammation of the bronchi. So typically it's primary and secondary bronchi. So if you have acute bronchitis, it's an infection. It's generally pretty strong and a temporary infection of the primary and secondary bronchi, where the primary ones are the ones that split off of the trachea. And then as soon as they enter into the lungs themselves, they split into different regions of the lung to become the secondary bronchi. So you're talking about the main air tubes, essentially, that lead into the lungs and then that kind of disperse air throughout the lungs themselves. Pneumonia is an infection. It's caused by a bacteria. It can also be viral pneumonia as well. This one's a little bit more concerning because it actually gets all the way down to the alveoli. And so what happens with pneumonia is the alveoli will actually fill up with fluid. So it's kind of like almost a very mild physiological form of drowning. This is basically what happens to you when you have pneumonia. Because remember when we talked a little bit about earlier, the respiratory membrane. Remember we talked about that zone where the oxygen and the CO2 had to cross over the alveolar epithelium, then it had to go into the capillary epithelium and then into the blood. And that distance had to be as small as possible because the diffusion is limited by distance. Well, what happens when you have pneumonia is it causes a thickening of that distance. So instead of having something like this, where you have a very simple squamous line of cells, here's your basement membrane. Let's say that's the capillary, okay? And then on top of that is going to be another basement membrane, and then your alveoli. That is the simple squamous cells of the alveoli. Very thin, right? Very easy to get across. But when you have pneumonia, what happens is the fluid starts to build up on this side, creating thickness. So now all of a sudden your oxygen is out here trying to figure out how to get through this big mass of thick, sticky fluid. Makes it very difficult. Even though you're breathing in the air just fine, it's having the oxygen is having to get across a greater and greater distance, making its acquisition, its uptake, a lot less efficient. And so what basically you end up doing is slowly suffocating over time. And this is basically the same thing that happens in drowning. Drowning is, there's nothing inherently bad about water, is matter or fluid in that matter, for that matter, right? Because if we had enough oxygen in water, we could breathe it just fine. It may feel a little funny, it may feel a little uncomfortable, but if there is a lot of oxygen in water, we would be able to breathe it just fine. The reason why we drown isn't because it's water, it's because there's not enough oxygen in water to fuel our needs for oxygen. And so that's so in this case, what happens is there's just not enough oxygen getting across that barrier now because it's made thicker by that liquid, that fluid from the pneumonia. And by the way, anything that creates that fluid in the alveoli has a similar sort of an effect. And of course, we had tuberculosis, which for the most part was the bane of the 19th century, and it kind of went out of style, so to speak, for a little while there in the 20th century. But it seems to be making a comeback because we have now antibiotic resistance forms of tuberculosis. This is a bacterial infection. And what it'll do is these bacteria will lead to these hard pellets, if you will, called tubercles that lodge themselves in the lung tissue. And these are basically bacteria that are kind of like holed up inside these little hard granulations. And those are the tubercles. That's where the term tuberculosis comes from. It's a condition of tubercle formation. And so since you have bacteria inside these little kind of pods, these tubercles, then they can come out of those tubercles at any point and infect more and more respiratory tissue and create a lot of problems for your breathing. So it's kind of what they look like, sort of picture-wise, sort of your pictorial view of it. So here you can see in pneumonia how your alveoli will start to fill up with fluid, basically kind of like physiological drowning because you're not able to get as much oxygen. So you can see how your alveoli slowly fill over time. And then with fibrosis, this is basically connective tissue that will build up in the lungs. So if you have damaged lungs or things like that, you'll have these hard connective tissue fibers that build up and basically compromise the accessibility of these alveoli, so they can't fill up with air anymore, because you basically have them stapled shut. The tubercles, you'll see, are going to be these like large nodules that you see inside the alveoli that aren't supposed to be there. Those are filled with bacteria. So again, compromising the structure and the normal function of your alveoli. This is where that respiratory membrane is, remember. So you compromise your alveoli, you compromise your ability to be able to function normally. And then emphysema is basically where you get the damaging of alveoli. So notice how you've lost the actual alveoli clusters. And so you're basically damaging and ruining. So instead of having like a little area with all these different little alveolar clusters like this, instead what's happened is you've broken all those up and now you just basically have big ones. So you're losing surface area. And we know the surface area is an important thing, right? So basically you have less working surface to be able to actually get your oxygen across on. So that leads to less oxygen over time. Emphysema is another one where as you start to reduce your gas exchange, it's kind of like a slow, very slow suffocation. Okay, that's what a lot of these respiratory disorders are like. It's like you just get, it gets harder and harder to catch a breath. And then eventually you just can't catch enough breath to sustain your needs. Bronchitis, that's the inflammation of your bronchioles. So you'll see that they get irritated and they start to secrete a mucus on the inside, which creates this blockage in your bronchioles. And of course, you'll cough up lots of mucus. And since it's inflammation, that means your immune system is at play there, right? So your white blood cells are there. So that's where the pus comes from. And of course, asthma is different. So you're not building up a discharge. What's happening is you're abnormally closing off your airways with those smooth muscles that are in your bronchioles. And so you have an abnormal response to constriction of your bronchial pathways, usually due to some sort of a pollen or something of that nature, some sort of an allergen. Okay. So those are most of the infections that we have. So what about some of the restrictive disorders? So basically, when you have a restrictive pulmonary disorder, what you're doing is you're cutting out and you're reducing your vital capacity. Remember, vital capacity was the one we talked about last time we talked about pulmonology. This is the one where if I have you basically go all the way to the very, very top of your breath, and then I have you exhale all the way down to the very, very bottom of your breath, that's your vital capacity. That's how much you have access to. So the very bottom to the very top. Now, if you have a restriction or a restricted pulmonary area, like for instance, with fibrous connective tissue, so this is where your pulmonary fibrosis comes in. So if you have your fibrous connective tissue built up, then what will happen is you're reducing the amount of your inhale. So if you're not able to inflate those alveoli because they've been compromised due to this fibrous connective tissue buildup in your lungs, it's typically scar tissue is what it is, right? Then what that means is when I tell you to go to the very top of your breath, the top of your breath isn't so high anymore because you're not able to get to those extra alveoli because they've been compromised by all the scar tissue. And so as a result, then you can't inflate properly, and we can actually measure that. So like when we have you do a breathing test in a pulmonologist's office, we can actually see that. We can see that your inspiratory reserve, right, that's the very top of your breath, isn't as high as it should be. And that tells us that there might be some scar tissue in there or some issue going on, some pulmonological issue going on. So for instance, if you're inhaling lots of non-inhalant types of particles, for instance, sand, if you inhale a lot of sand, I'm looking at you sandstorm folks who live in desert areas where there's lots of sandstorms, like in areas of Northern Africa in particular, right? So you have to be careful. You don't just ride out the sandstorm just breathing like this. You always have to cover yourself up, right? So that you're not inhaling those sand particles. Otherwise, you're going to start getting restrictive pulmonary disorders. You're not going to be able to breathe in very deeply. Coal dust, right? So the miners, the coal miners, as they inhale that coal dust, there's nowhere for that coal dust to go, right? I mean, it's basically stuck in there. So you can't breathe that out. You can breathe it in, but once it actually makes contact with the fluid in your alveoli, it's now turning into coal mud. And that starts to compromise your alveoli. It's that same idea I was talking about, like breathing in volcanic ash, creating like little layers of cement in your alveoli. It's the same exact idea. Asbestos users, that's even worse. And fiberglass is really bad. It's one thing I hate doing in the house is insulation. Not only does it get all over you, and you have to like shower like continuously for like weeks at a time just to get it all off of you, but I mean, you're breathing in those little tiny fibers of glass, and that's going into your lungs, and it doesn't come back out, right? So asbestos is the same idea. Basically, asbestos is a type of insulation, and it's not the same as fiberglass, but it's similar to fiberglass. But basically, it creates these little spicules, these little particulate pieces that are airborne. And when you inhale them, you can't exhale them, right? Just like with fiberglass, you inhale them, you can't exhale them. This is one of the reasons why these days, when you see somebody who's working in insulation, they've got the full respirator on with their carbon filters and everything. Why? Because those fiberglass fibers can be lethal, right? Which is also one of the reasons why one of the things I hate the most, house chores, is crawling around in the attic for any reason whatsoever, right? Because it's full of fiberglass. Most of those fiberglass shards and dust, fiberglass dust, has settled over the years. But if you're up there climbing around trying to like maybe wire a ceiling fan or something like that, you can kick those fiberglass shards back up again, and you'll be inhaling them, and you can't feel them. So you don't necessarily know that you're even getting them on you. You can't see them. The only way you can see them is a lot of times I'll come out of the attic and I'll get out to the sun in the yard and I'll see all these little glimmering glints of light all over my clothes. And it's like, okay, I got fiberglass all over me, right? And that also means, guess what? I also inhaled a lot of fiberglass as well, right? So those are things always to watch out for. But these cause problems because they can essentially compromise your ability. Because when you get those pieces in there, what they do is they become an irritant, right? So you get those little fiberglass shards stuck in your lungs and they can't get out. So what happens is you basically build connective tissue around it, kind of sealing it off so that you don't create any further irritation. The problem is the more of those fiberglass shards you have in there, the more alveoli you're sealing off and the less full breath you can get. Makes sense? And so some of these, like for instance with asbestos, can lead to cancer. For instance, mesothelioma, right? We've seen all the commercials. If you or a loved one has worked with asbestos and may be subject to mesothelioma, call this because we want to go make a lot of money off of you by going after whoever it is. But this is one of the reasons why now asbestos in particular is really problematic, right? Because if you go to a building, you can't clean it up. When you see asbestos, it's like you can't touch it. It's very difficult to manage because if you do it the wrong way, then you can actually do more harm than good. It's kind of like letting the sleeping dogs lie. Asbestos that was maybe laid down in the 50s or 60s, if it's just laying there, it's probably safer to just lay it there and just sort of seal it off than it is to try to remove it. Because when you remove it, you're going to basically disturb all those asbestos crystals. They're going to get in the air, into the ventilation, and then basically you'll essentially fill the entire building with asbestos. By the way, for those of you who have classes in Cherry Creek, anybody have right? When I first started, that was back in 07, we were fixing Cherry Creek. It was the downstairs area, and they were kind of revamping it. And there was asbestos in there. And they kind of had it all sort of ventilated out and sort of, but they had to leave it there because to disturb it would be to essentially contaminate the entire building with asbestos crystals. And that's not uncommon in this area of the city. Probably more buildings than not on this campus have that same problem, which is one of the reasons why we say, well, why don't we just implode some of these things and rebuild over them, like the warehouse district? Like, if you ever notice, there's a lot of buildings there that seem like, well, why don't we just sell this building off, then have somebody come in and tear it down and build something else there, right? Something useful. Well, in some cases, the reason why they can't do that is because back when that building was made, back in the day, asbestos was used in order to insulate it. And so now they can't really tear it all down without creating a massive environmental hazard. And so there it sits for an indefinite period of time before we can figure out how best to safely deal with it. Okay. So asbestos itself, now we don't use that anymore, right? But by the time we realized what asbestos was doing, it was a little late. We'd already used it in a lot of buildings. It was a common insulation for a lot of buildings. Yeah, Lizzie. Well, if you do, the problem is all those microcrystals will get released into the air. Now, fiberglass is a little less that way. Asbestos is really loose, and so it's easier to get those crystals in the air. And so it's really hard to kind of clean up after you did that. And in some cases, some buildings do that. Like, for instance, if there's like a totally abandoned building, they might take that approach, where they just basically say, listen, I know we're going to disturb asbestos. It's not going to be a safe place to be for a while, but we can suck all this asbestos out. The air is going to be contaminated because all those asbestos crystals are still going to be irritated. They're going to be in the air. And so we're going to have to allow some time for that asbestos to settle and to sort of a period of time for that to kind of to become safe again before they can do anything, right? So I mean, it's really tricky. It's very difficult because it's so easily dispersed in the air. Because you don't touch it. So like when you seal it up, the idea is you don't disturb it. You just kind of like seal it up and you kind of like eliminate it. So you just basically kind of cordon it off, but you don't touch it, and you just sort of build around it so it's not disturbed ever. Does that make sense? Yeah, no, I mean, there's like you have to be very careful. That's the reason why, like when they ran into that in Cherry Creek when they were first remodeling it, and that was been years ago. It slows everything down, right? Because you have to really approach it very carefully. And in some cases, if it's like in the way of your remodel, it's kind of like a deal breaker. It's like, we can't remodel this room without disturbing the asbestos, and we don't want to do that. So we're going to have to just leave the room as is and do our best. So we can do what we can without touching it or disturbing it, but we can't really do what we want to do because it would require us to disturb the asbestos. And we want to use this, right? We don't want to just leave this as an abandoned space. That makes sense? It's very difficult to deal with, which is one of the reasons why we don't use it anymore. And it was, by the time we realized how bad it was a little late. We'd already used it quite a bit. And at this point, we switched from asbestos to fiberglass, which is a lot better, but still has a lot of the same problems to it. That's why I don't like working with insulation, like at all. Even if it looks like it's well behaved and tame, and it's like, no, it's made out of fiberglass. It's a problem, right? Okay, now going from restrictive to obstructive, this is basically a situation where your air is not actually moving freely through your airways. So we have things like chronic bronchitis, emphysema, asthma, for instance, chronic obstructive pulmonary disorder, COPD. And so these tend to be recurring for the most part, and they also tend to be more pathological in nature, right? So these are kind of deeper concerns. So like with chronic bronchitis, this is a situation where you have kind of a constant inflammation, not like constant, like it never goes away, but a chronic sort of a flare up of an inflammation of your bronchi. And so as it does that, it's going to fill with mucus. So we saw that one before on the previous slide. And so as they kind of go into this sort of disease state, if you will, they're like worried, and they're kind of like they're responding to something, right? They're going to get this mucus discharge. Now, remember, when you get this mucus discharge, especially when you get the pussy component to it, that's telling you that your immune system is responding to something. Now, whether or not that something is legitimate, right? Like pollen, for instance, one would argue that that's not a legitimate response. I mean, pollen's not going to kill anybody, right? It's your response to pollen that kills people. It's not the pollen itself. Pollen's not dangerous in any way, shape, or form, right? It's not a pathogen. It's not designed to kill people. It's a reproductive structure of plants. So it's not dangerous at all, but your body treats it like it's some sort of a pathogen, and it responds to it that way. So that's what happens when you're talking about mucus development and pus development. And over time, with this chronic, it could create degenerative types of effects where some of the tissue begins to degenerate. For instance, loss of cilia in your respiratory tract. And this oftentimes, and usually when you take a look at chronic bronchitis, it's not common for most healthy individuals. However, usually when you see it, you're looking at a smoker, right? The reason is because you're assaulting your respiratory epithelium with a constant barrage of smoke. And you're telling your respiratory system that things that shouldn't be in your body are in your body quite routinely. And so it's giving your body sort of this constant sort of, I'm on my guard against these smoke particles. And that's where you kind of start to get a breakdown in the system. You basically exhaust the system, you get degenerative changes, you get loss of cilia. And so it gets harder and harder to get these smoke particles out of the respiratory pathway before they enter into the lungs. So other types of things can also cause it. By the way, it's smokers certainly, absolutely, right? Because that's essentially like, willfully inhaling pollution. However, if you happen to live in a big city, I'm looking at you, Denver, with your inversion layers that are brilliant orange over the valley. We can see that from Green Mountain and from the other parts of the mountain. Pollutants. So if you live in places like LA or other areas like that, this can also cause chronic bronchitis because it's essentially kind of like a muted version of basically smoking. Living in a big city is like smoking at a very low level for most, just about everybody. So if you add to that a smoking habit, then your body's like, are you ever going to inhale any oxygen anytime today? Right. And one of the worst things you can do for your physiology, for your body, and for your health is to be a smoker. Right. That is categorically, doesn't matter what discipline you're in, doesn't matter what specialty you're in. Just about every single doctor on the face of the planet agrees that smoking is the number one worst thing you can do for your health. So if you haven't started smoking, don't start. Okay, that's just the best way to do it. If you have started smoking, then do whatever you have to stop smoking, because it is by far much more deleterious to your health than anything else you can do. Even a bad diet is nowhere close to how destructive smoking is to your body. Okay. So, matter of fact, the doctors that I used to work with would actually fire patients if they didn't stop smoking. I mean, they were blunt about it too. They were like, listen, you're a heart patient. I'm going to tell you right now, if you don't stop smoking, go find somebody else, because I am not going to touch you if you don't stop smoking. That's how adamant some of those doctors were. So, obstructive pulmonary disorders, things like emphysema. We talked a little bit about that one, right? So this is a chronic one. This is obviously a smoking one. But basically, it's typically caused by kind of a chronic life, if you will, of smoking. And so what's happened is you've basically damaged your alveolar walls. You have less surface area for gas exchange. So you don't have as much oxygen coming to the heart and brain. So it's like slow, incremental suffocation. Your lungs, the ability for them to basically expand and to readopt their shape, that's the recoil piece, is greatly reduced. So it becomes less elastic. And so which makes it difficult to exhale. And so you're starting to compromise now your ability to take in a breath, in addition to your ability to get oxygen across that respiratory membrane, because you have less respiratory membrane to use now. As a result, you're going to start to deprive your brain slowly over time of oxygen. And this is like a slow creep. We're not just talking about like head rush, right? Head rush is an acute loss of oxygen to the brain where you start to black out, right? This is more like kind of the physiological version of slowly putting a pillow over your face. That's what this is like. And so as a result, it's going to start to deprive normal function of the brain because of a lack of oxygen. It's going to manifest itself in different ways. For instance, it can create depression, lethargy, and of course, irritability. So going after the limbic system and your ability to process emotions. So it can go after a lot of that. Most of the time, emphysema is a one-way street. By the time you've gotten to emphysema, you're in serious trouble. You're probably looking at what's going to take you off this planet. That's probably what's happening. You can, however, get a lung transplant. So basically a lung volume reduction surgery, where essentially you can remove the diseased lung. And then what that does is it kind of gets the spatial, this basically removes physical barriers and allows targeted air delivery to healthy tissue. Remember when we said that you have air all the way through your respiratory tract, right? So you have it in your nasal cavity, you have it in your mouth, you have it in your esophagus and your trachea and your bronchi, and all that is useless, right? That's called dead space. And it's only the air that's in the alveoli that matters, right? That's that physiological hotspot, because that's where the respiratory membrane is. That's where your blood capillaries are, where you can do the gas exchange. Well, when you have emphysema, what that means is you have more dead space, right? So basically that means that not only is you have the normal dead space of the stuff in your nasal cavity and your trachea and your bronchioles and stuff like that, but now you also have dead space associated with alveoli that don't work anymore. That's the diseased tissue. And your lungs are having to disperse the air throughout all the dead stuff and the living stuff. So if you take in 100% of your air and you divvy it up amongst dead and alive tissue, then your living tissue gets a small fraction of that total air. But if you were to remove the dead tissue, then that 100% of the air coming in is going to be more favored toward the healthy tissue. So your healthy tissue is going to get a greater fraction of the air. That's what this is talking about. Right? So it's talking about basically getting better delivery of air into the healthy tissue, or what little healthy tissue you have left. And that can be an increase. But here's the problem. This is, I mean, the problem with this one is this is only going to work if you stop smoking. Right? I mean, we've all seen the videos of, you know, somebody who's had like the little voice thing. That's because of their severe emphysema, right? And I've seen patients where they've actually taken the cigarette and they puff it through their little tracheotomy, right? I mean, it's like they're so addicted to the cigarette. It's got such a hold on them that even this, they're still smoking through. And that's usually somebody who has like a mouth cancer or kind of cancer up here in the upper respiratory area because of smoking usually. And so they basically kind of reconnect your breathing so you can breathe out of your little tracheotomy tube. And I've actually seen, I mean, videos of where people are like, and they're breathing and they can't stop. So this is only useful if you stop smoking. Otherwise, don't bother, right? As a matter of fact, back in the day, we used to do that, but there's more and more doctors actually, as these younger generations of doctors come out, there's more what I call aggressive doctors that come out that are literally like, listen, no, you're not going to get one of these unless you can prove to me that you've stopped smoking. Don't even ask, because we're not going to. So you have two different players here, right? Usually you have the insurance company who has to pay for it, because chances are you don't have the money to pay for an operation like this, right, to remove the dead lung tissue. And number two is the doctor has to be willing to do it. Now, before, the number two was never a problem. Doctors would always do it. But as these younger generations of doctors are now like, listen, no, sorry, unless you can prove to me that you've stopped smoking, I'm not going to do it. Same thing, by the way, for the alcoholics, right? Unless you can prove to me that you stopped drinking, don't ask me for a liver transplant. You're not getting one. Do you know why? Because you're going to die just the same. Because you are intent on killing yourself, and you have absolutely no intention whatsoever of changing that trajectory. And until you change that trajectory, why should I put it off? I'm not going to allow you to take a liver from somebody else when you have no intention whatsoever of cleaning yourself up. Same thing with this one, right? So there's a lot more doctors that are starting to get, I won't say nasty, but they're kind of starting to put their foot down, right? So a couple of other obstructive pulmonary disorders. Asthma is probably the most common one, right? So this is basically where we kind of get wheezing and breathlessness. A little bit of a cough going on as well. Generally speaking, this is triggered by some sort of an irritant. Oftentimes it's either pollen or tobacco smoke. Typically this happens when your smooth muscles around your bronchioles start to spasm a little bit. So typically it's not curable, but it is treatable with inhalers, things like Flovent, which is kind of a chronic maintenance inhaler, or albuterol, which is typically what you refer to as a rescue inhaler, that you essentially take it as you have a bit of an episode. Now, here's the problem. This particular phrase right here, asthma is not curable, is generally true, but specifically it's not. And the reason is because especially in Denver, and especially in the Front Range, there is a peculiar kind of an asthma. Oh, how should best to say this? There's a juvenile asthma type of a syndrome that we have that's pretty common in the Front Range, where a kid will have asthmatic types of presentations, and they will go on their inhalers, they will have their Flovent, and then they'll have their albuterol for rescue moments is like that. But as they're growing up, it's not uncommon to hear stories where, like right around just before middle school or something like that, they just didn't need the inhalers anymore. And they never had any more episodes of asthma. Now, that's not that the inhalers didn't cure it, right? But what happens is there is this, I don't know what else to call it other than a kind of a temporary version, especially here in the Front Range. It's actually a pattern that if you go to National Jewish, now I can tell you it's a thing, happens quite a bit. Matter of fact, our lab coordinator here has one of the lab coordinators here, not ours, but another one, had a son who had the same thing. Asthma as a kid, was taking all the inhalers, and then right around middle school, didn't need them anymore. Just stopped, just didn't need them. And my son's the same way. He has his good days and his bad days, but as he gets a little older, he's 8 now. So as he gets a little older, he's like needing those inhalers less and less. And there's a very, very clear pattern here in the Front Range of that. But it only seems to be those of us who are born in this area. I'm curious, how many of you native Denverites or native Front Rangers had a similar type of a trajectory? Early asthma, and then it just kind of went away. Hmm. Yeah, the big adapters. Yep. The spacers. Yeah, and it's like, and a lot of people have kind of similar stories where it's like, oh, I'm an adult now, I don't really need it anymore. And so it's not really a thing. And then you have late onset. I mean, I've had some people who are like, I've never had a problem with asthma, and then all of a sudden in my 30s, boom, it just started happening. And so it's there's a lot of question marks associated with that, but you don't cure it. It just comes and goes when it wants, and then you just sort of manage the symptoms with your inhalers. That's basically what you're doing. But in all cases, it's usually associated with some sort of an irritant. It's common for pollen, right? That's allergy associated asthmas, or some other types of triggers, or like in the Front Range, a lot of the National Jewish researchers, they kind of hypothesize and they think it might be a combination of things, that it might be a combination of the altitude with the pollution of the Front Range. Because pollution, remember, is like tobacco smoke, especially on fire days. And that's one thing I definitely do know. My son definitely has a harder time when the sun is orange, because half of Canada is burning down, and we're getting all that smoke blown into the Front Range. It is pronounced because we all feel it, don't we? Even if we don't have asthma, we all kind of feel a little kind of like on those ashy forest fire days in the summer, right? And so that is the tobacco smoke irritant piece of it. Okay. So that's a thing. And then, of course, the worst one would be lung cancer. And so with lung cancer, this typically is really bad, right? So this is a really bad cancer to get. I mean, not that you want to get cancer, but if you ever had to get a cancer, don't get this one, right? This is a really bad one. So this is a really aggressive cancer. And typically men get it more than women, generally speaking. And the first thing that happens is kind of similar to what happens in pneumonia, right? So basically you get a thickening of that lining, which increases or actually decreases the gas exchange efficiency. And so once that starts to happen, then eventually you start to see compromise in the normal functioning of the tissue. For instance, when you lose your cilia, then you're no longer able to sweep all those dust particles and things like that out of your respiratory system. So all of a sudden now your dust and dirt begins to accumulate and settle in the lungs. And then that's just like the beginnings of it. You may not necessarily know that you have lung cancer at this point. You just may know that you're coughing a little bit more than you expect, or that your coughing is persistent and doesn't go away. Why? Because that mucus in your lungs keeps collecting and you can't get it swept out. And so you kind of start to feel it getting down deep into your lungs before you can actually do something. So it's like getting down in there a little too far, as opposed to staying up here in the upper region of your lower respiratory tract so you can cough it out easily. Then shortly after this, you start to get a classic marker for cancer, which is cells that have these weird wonky nuclei in them. Because remember, cancer cells are rogue. So they're not doing anything normally. They're not listening to instruction. They're not listening to supervision. They're doing whatever they want. And so their nuclei tend to be very, the very classic look of a cancer cell is having nuclei that are typically warped and disfigured, because they're just going through cell cycle without fixing themselves. And so they're accumulating lots of damage and lots of brokenness in them. And this is what's happening in the lining, like in your trachea. And then what happens is, as these atypical cells begin to populate, then they'll start to create tumors. And those tumors can be in a single location, which is called in situ, or at the site. That's a Latin term for at the site. So the final step basically is the worst one. So now you're at a tumor stage, right? So basically you get a tumor of these abnormal cells that are starting to create a problem. What they do is they obstruct normal cell function, wherever they happen to be. They could be in the trachea, they could be in the lungs, they could be in the alveoli. So anywhere they are, they can create obstructions. These tumors can create obstructions so that the normal cells can't do their job. And then at that point, the last step is basically when these cells of the tumor begin to break loose and they move around. This is what's called metastasis. And when they start to move around, they're able to move around your body, and they can lodge in other areas of your body. So the other tumor, which is now shedding cells and they're radiating throughout your body, can still continue to grow. They'll block physically. It'll be like a big ball that starts to block your airway and slowly, almost kind of like the hands of cancer, like literally like grabbing you around the neck and like closing off your airway. That's probably what it would feel like. And so if it happens to be in your lungs themselves, you can remove a part of that lung. And that's oftentimes something you can do, because you can live without a lobe of your lung. So if there's a tumor inside one of the lobes of your lung, you can eliminate that lobe and you could still probably have enough lung tissue to be able to survive. But you have to get this before metastasis. Because if the tumor has allowed to go to the point where it's starting to break off and spread throughout the body, at that particular point, that's usually what we refer to as stage 4. That is usually the point at which you are advised to start making arrangements, start crossing off those final things off of your bucket list, start saying your final goodbyes to your family and to the people you love, because there's only one outcome for this one. Right, so that's the last thing you want an oncologist or any doctor ever to mention to you, is the term metastatic. Fill in the blank, anything. Because what that means is now all of these cancer cells that originated from your lung, they can lodge anywhere. And so even if it's not your lung cancer that gets you, these metastatic cells could lodge in your brain and create brain tumors. They could lodge anywhere in your body and create tumors anywhere in your body. That's the reason why metastatic cancers are so dangerous, is because it's, even if you start off with something that's relatively benign, right, of cancer that's technically, not a killer, so to speak, right, one that's easy, like a prostate cancer, for instance, is an example of one of those, right? If caught early, the prognosis for prostate cancer is actually quite good. Testicular cancer is another one, right? If caught early, the prognosis there is quite good. But if it spreads, then there's no telling what's going to happen, right? So that could spread throughout the body and it could lodge and create tumors in even worse areas, like, for instance, lung cancer, or in your brain, or in other areas that are going to be much, much more lethal, right? So that's one of the reasons why there's so much emphasis, especially on screening and self-evaluation, right? I mean, every doctor will be like, listen, you have to check yourself down. Like when you're in the shower, you have to know how to check yourself out and make sure that there is nothing, potentially that's going on, because if we catch it early, then you've got a really good outcome. But if you wait until you're feeling bad, you're probably basically, there's not a lot of hope at that point, right? So this is actually what the lung looks like. So on the left, you can see is a normal lung. So you can see nice little fatty deposits there, kind of nice and red. And then lung cancer lung. So you can see the blackishness of it. Basically, oftentimes the black is associated with necrotic tissue. Oftentimes when tissue dies, it turns black. Think about frostbite, right? Have you ever seen a frostbitten finger? What color is it? It's black, right? That's because whenever tissue dies, it oftentimes will turn black like that. So that's oftentimes a necrotic look. So you can see this individual. I kind of feel bad for this individual because they must have had a horrendous time breathing with that much necrotic tissue. This is probably what got him. My guess is this is probably an emphysema lung. That's my guess. Okay, so that's the end of 10. So I'm going to go ahead and fire up 9. Should have like elevator music or something like that to So chapter 9 is going to be digestion. So let's go ahead and take a look at our digestive system. You'll notice there's some overlap, right? Because the upper respiratory system is also doing double duty up there in the head and the throat. It's also doing double duty with the digestive system as well. So when you take a look at the digestive system, what we're looking at is essentially one long tube called the gastrointestinal tract. And so the goal of the digestive system is to basically break down and hydrolyze your food molecules. And so you're going to take your food, you break it down into smaller pieces until you get down to your monomers, right? So your monosaccharides, your amino acids, fatty acids, glycerol, nucleotides, right? So basically all those building blocks, remember we talked about in the macromolecule section, we talked about building proteins, building carbohydrates and things like that. So those monomers, if you will, those are going to be coming from your food. And so you have to basically take those individual monomers and then you're going to transport them into your blood so that your cells can have the nutrients that they need in order to build the molecules they need in order to function. So here's basically your digestive system. Notice we start off in the same place we did with the respiratory system. We're going to start off in the head. And so you can see that basically instead of taking a look at the nasal cavity, we're looking now at the oral cavity. So that's essentially where digestion starts. And of course, we're going to move that back into the pharynx and the esophagus. You also have some accessory organs up here. So for instance, your salivary glands, which are basically going to be part of your digestive system associated with your oral cavity. And then as it moves down your esophagus after you swallow, it's going to be moving into your stomach. And then from your stomach, it's going to be entering into your small intestines. There's 3 main regions of your small intestines. And this is where you're going to be doing a lot of your absorption. This is also where your food takes on a bit of an identity shift. So as you swallow it, we refer to it as a food bolus, right? Which is kind of the paste that you swallow, right? And then in the stomach, it's liquefied into now what we call chyme. So chyme is basically your food bolus that's been liquefied in your stomach. And that's what's moving through your small intestines, where basically absorb your nutrients and things of that nature. And then from there, it's going to go into your large intestines, where you'll take a lot of your water back out. And then the solid material that is not digestible or absorbable is basically deposited in your rectum, whereas then eliminated in your anus. Now, there are other organs associated with the digestive system that are not part of the tube. The tube basically houses an in-hole which is your mouth, and an out hole, which is your anus, right? And so all of these structures are part of the tube: mouth, pharynx, esophagus, stomach, small intestines, large intestines, rectum, and anus. That's all part of the tube. That's called your GI tract. However, there's what's called accessory organs, which are not accessory because they're less important. They're accessory because they're not part of the main tube. So for instance, the liver and the pancreas and the gallbladder are all accessory organs that are associated with the digestive system, but I would argue that these are incredibly important organs as well. So let's go ahead and take a look at the process. The first thing that you do in your digestive system is you have to ingest or intake food. So ingestion is the first function of the digestive system. So you're going to take the food in through your mouth, and then immediately you're going to begin the process of digestion. And there's two different types of digestion. Basically, digestion is simply making big stuff smaller. That's essentially what it is. And you have two different versions. You have what's called mechanical digestion, basically where you physically break down the food material. Chewing, for instance, in the mouth is a form of physical and mechanical digestion. Also, when your stomach is contracting its smooth muscles to basically churn the food bolus, it's almost like taking a lump of dough, bread dough, and kneading it with your hands. You're physically mashing on it and basically distorting it. That's what your stomach is doing. It's like you physically sort of mashing on that food bolus in your stomach, and that's a type of mechanical digestion. But it begins already in the mouth with chewing. You also have chemical digestion. In this case, what's happening is instead of physically going after it, you basically use digestive enzymes to start cutting these macromolecules apart. So for instance, you're cutting your proteins into amino acids. You're cutting your carbohydrate monosaccharides and so forth. Now, where does this begin? It begins, believe it or not, in the mouth. You don't wait for chemical digestion. It begins in the mouth, and it continues in the stomach. It kind of changes form, and then it really kicks off in the small intestines. That's where a big chunk, the heavyweight stuff, is happening, is in the small intestines. Okay, but you don't wait for it. You don't wait to swallow your food before you start going after it. Okay. So when you have this different areas of digestion, you have, first of all, ingestion, digestion, and then movement is going to be. So movement, once you actually start to chew this up and mixing those enzymes with your saliva, right? That's basically where your chemical digestion is coming from. Your saliva is basically a mixture of water, mucus, and enzymes. And so as soon as you actually start chewing, you're mixing that food with your saliva. And your saliva is doing a couple things. First of all, it's making it softer so that you can swallow it, right? But it's also infusing that food bolus with those enzymes that already start to go to work on chopping up those nutrients that you've just eaten. Then you have movement. Basically, this is where once you swallow it, your food is going to be passed from one organ, like for instance your esophagus, to the next, like for instance your stomach. Now, normally when it's moving through your GI tract, it moves with a round of muscle contractions called peristalsis. Peristalsis is kind of like a uniform rhythmic wave of unidirectional muscle contraction. It's a lot of words. But think of peristalsis kind of like you squeezing a toothpaste tube, right? You squeeze a toothpaste tube in a single direction, don't you? When you grab onto the toothpaste tube, do you look forward to the toothpaste coming squirting out both ends at the same time? No, because one end is closed, right? So when you squeeze onto the toothpaste, when you put pressure on that, it wants to go both directions, doesn't it? But it can't go one direction because it's sealed up by the end of the toothpaste tube. So it only has one way to go, doesn't it? Which is out of the tube onto your toothbrush. Okay. That's very much like peristalsis. Only in this case, let's imagine you have this really, really long toothpaste tube, right? And your job is to get it out of the tube. So what you do is you basically kind of start doing this sort of coordinated contraction, right? You kind of squeeze on one end and you kind of put your hand on the front end. You kind of keep squeezing it so it moves forward. You kind of squeeze it and squeeze it so it keeps moving forward. It keeps moving in that forward direction, right? That's what peristalsis does. So that's that rhythmic wave of contraction. So I squeeze with one hand in one area, and then the other wave is going to squeeze in front. But notice what I do. If I don't want that to come back at me, what do? I don't let this hand go, do I? That blocks the reverse direction. That gets you that unidirectional hit. So when I squeeze with this hand, it only has one way to go, forward. And it's not until I squeeze with this hand that I let this hand go. And then I do the same thing. I hold this hand in place to block backward flow, and I squeeze it again so it only goes forward. That's exactly what peristalsis does. It's a wave of rhythmic contractions where one group of muscles will contract, scooching the food bolus in one direction. But before this one lets go, the next one will squeeze, further shooting it forward, and then this one will relax. So you're doing this. Like that, and that's going to squirt the food bolus in one direction. That's peristalsis. Okay. Now, once you're kind of moving forward, you're also still breaking it down both chemically and physically, mechanically, and then you're going to get to absorption. So this is basically where you're going to be moving the nutrients across the GI tract, and it's going to be going into the bloodstream. So that's your absorption, and then you're going to get elimination. So this is basically once you've absorbed everything, you've got a lot of indigestible waste, things that you can't absorb. And so basically you pack this up and you eliminate, or you defecate. Basically you poop. You poop out all your waste. So in your feces is essentially all the undigestible material that your body was unable to absorb. So it picks and chooses what it wants, and it lets the rest of it go. Okay. So theoretically speaking, if our digestive system had the capacity to absorb anything, like if it was maximally efficient and it could absorb most everything, like we didn't have limitations, then you would imagine a body that had maximum absorption with very little waste. That would be evidence of eating something that's highly absorbable, right? So that's not us nor anything else on this planet. So, but it's kind of an interesting sort of a little thought experiment to think about, right? What would happen if our digestive system was perfectly efficient? Then you wouldn't expect to have to be able to sit on the pot ever, because your body would be able to make use of everything you put in it, right? Of course, obviously that's a pipe dream, right? But that's kind of what that would look like. Okay, so let's go ahead and take a look at the wall of the digestive tract. Basically, what we're looking at is this GI tube, right? Now, the first thing to always remember is that in this tube, we have the term lumen, which is the inside of the GI tract. It's the inside of the tube. And actually, the term lumen always means the inside of something, right? So the lumen of a blood vessel is the inner portion of the blood vessel where the blood is. The lumen of the stomach is the inside of the stomach where all the food is, okay? So lumen simply means the inside of something, and typically the inside of something that's hollow, right? That's designed to carry something in it. But when you take a look at the GI tract, one of the things that ties together the entire tube from your esophagus all the way down to your anus is that they are all composed of the same layers. So just like we had layers of arteries and veins that were similar, they just kind of buried as they went through the body. We have the same thing also with the digestive wall. The digestive wall has the same layers. It just has slightly different nuances and structures depending on where you are in this GI tube. The first layer and the innermost is the mucosa. So basically, if you get even further in there, we're talking about the lumen, or where the food is that you've just eaten that's passing through. The first layer, the innermost layer, is the mucosa. Typically, oftentimes, this will produce lots of mucus for protection, but it also will produce digestive enzymes. This is basically the area that I refer to as the physiologically critical area. And so not only are you producing enzymes, but you're also absorbing nutrients here. So this is a really, really important piece. You don't want to damage the mucosal lining of your GI tract. Bad things are going to happen, okay, if you do that. Underneath the mucosa, so typically this is an epithelial liner. And you're usually looking at epithelial liner of columnar cells. That's what you're looking at. Now, underneath this epithelial liner is a connective tissue layer called the submucosa. That makes a lot of sense, doesn't it? Because remember, we said that whenever you have an epithelial liner, you have to have some sort of foundation to put it onto, and that's connective tissue. Well, here's your connective tissue foundation. Just so happens that in the submucosa, you also have a lot of other interesting things in there as well. For instance, you've got blood vessels in the submucosal layer. By the way, these blood vessels are the ones that are absorbing the nutrients. You also have lymphatic vessels. Remember, we said the lymphatic vessels are the ones that also absorb your lipids. So these guys are the ones that are called the lacteals. These are the ones that absorb your lipids. And then, of course, you have nerves there as well to coordinate and control local activities in this area. So the submucosa is very important because this is basically where your absorbing materials are. This is how you absorb your nutrients. If you have pathology in your submucosa, you're probably not going to be able to absorb nutrients, even if you eat them. Then number 3 is going to be another layer called the muscularis. Now, this is a muscle, the region of smooth muscle. In most areas of the GI tract, you have 2 different types of muscle. You have an inner circular layer and an outer longitudinal layer, with the exception of the stomach. The stomach has 1 extra layer called the obliques, so it has 3 layers. So everybody else in the GI tract has just the 2 layers. And then the outermost portion is the serosa, which is an outer connective tissue lining. That weaves into the peritoneum. Remember, the peritoneum is the serous membrane of the abdominal cavity. So just like we mentioned before, right, that connective tissue outer layer is woven into the surrounding connective tissue and membranes to basically stabilize it all and keep it all in one place. This is one of the reasons why your digestive organs, like if I jump up and down, my digestive organs aren't bobbling around and shaking all over the place, right? Because they are all woven into my peritoneal liners that are basically keeping all this stable so that you guys can run from the lion, for instance, right, and save your life without having to feel like your guts are basically bobbling back and forth and just getting hammered because you're just like, you know, they're just like bobbling everywhere. So that keeps everything in place and tethered and anchored down in your body. So all of them have this liner. So here's kind of what it looks like. So you can see, first of all, you have the lumen, the inside portion of your GI tract, and then your mucosa, which has this particular piece right here. So you can see this this epithelial liner, which oftentimes is wrinkled like this to increase surface area. And then underneath that is going to be the submucosum, which is this little pink piece of it that kind of protrudes up underneath the mucosal layer. So that's basically where all of your blood vessels and lacteals are. And then you can see your muscularis layer, which is this layer right here. So that's your muscularis. You can see your 2 different types of muscle. For instance, here's one type here, And here's the other type here. So you got circular up here and you got longitudinal on the bottom. And then your connective tissue piece, which is your serosa, is all this outer piece right here. So that's your serosa, your connective tissue sheet that will basically interweave. So you can see how it basically interweaves into this membranous sheet, right? That's basically the peritoneal membrane. And you can see also how the peritoneal membrane also creates a nice little structure so that your nerves and your blood vessels, your arteries and your veins and your lacteals can basically be transported from one region of your GI tract to another. So it basically creates this kind of web-like structure that allows you to be able to sort of carry your blood vessels to these particular areas so that they can absorb those nutrients, right? So they're very vascular. Now, this, I'm just going to talk about these last two, and then I'll cut it off at 11. So a couple of conditions that you see. Diverticulosis is essentially where the mucosal lining, essentially is pushing through the other layers. And so it creates these little pouches where food collects, and that creates inflammation and irritation. And diverticulitis, which is inflammation, is where it becomes, these little pouches become infected. So if you get like a pooling of food in that area, then these little pouches can become affected, and that gives you diverticulitis. So the other problem with pouches is that if you've got, so for instance, carcinogenic compounds that happen to get stuck there, then they can create an abnormal chronic exposure of a potential carcinogenic chemical that might be in your food, right? That's the reason why those are important and difficult. Different types of bowel disease. So we have IBD, which is inflammatory bowel disease, and irritable bowel disease. So basically these guys will give you chronic diarrhea, and this is like an inflammation of this area, or an irritation. So it's in either an osis or an itis of natures, of one nature or another. And so you can either get chronic diarrhea or abdominal pain or fever or weight loss if you have IBD. If it's IBS, oftentimes what will happen is you get contractions of the muscularis. So these kind of like muscular contractions that are abnormal, right? They're abnormally strong. And so it's almost like cramping in your intestinal muscular wall, which creates a lot of pain. And then it can also create constipation and diarrhea. And so we're still looking into those particular disorders to figure out why exactly they happen to some people and not to others. So what we'll do is we'll start with the mouth and start working our way through the GI tract. And we'll start doing that next time.